This is our first webinar in the SUD integration work stream. It's advancing the integration of SUD treatment and recovery efforts across the crisis care continuum. One person cannot hear me. Can everyone else hear me?
Yes.
Excellent. All right, next slide, please. This wouldn't be a real webinar if we didn't have a disclaimer. So the views expressed here do not necessarily reflect the official policies of HHS, nor does the mention of trade names, commercial practices, or organizations imply endorsements by the US government. Next slide. For a little background on the Crisis Systems Response Training and Technical Assistance Center, SAMHSA has selected Altarum to provide TTA support to states, territories, tribal organizations, and community partners across the 988 Suicide and Crisis Lifeline and Continuum of Care. We do this work with our partners from W2 Consulting Corporation and Change Matrix LLC, who both have extensive experience in this field. The Crisis Response Systems Response Training and Technical Assistance Center was formed to support the continued growth of the 988 Lifeline and build a more robust crisis care system. Next slide. We have 3 learning objectives for our workshop today. The first being to understand the opportunities and challenges of integration within the crisis continuum. The second, to describe how an action plan can bring about effective organizational and system change. And finally, to define further opportunities and resources that'll be available through the 988 TTAC for integration efforts across the continuum. Next slide. Before we jump into our content session, we want to recognize our SAMHSA partners in this work. First is John Palmieri, the Interim Director at the 988 and Behavioral Health Crisis Coordinating Office. Next slide. And Jill Mays, the Division Director of Crisis System Transformation for the 988 and Behavioral Health Crisis Coordinating Office. Next slide. So today's session will be led by our Altarum workstream team. The first is Stephanie Legallo, then Tiffany Lombardo, and me, Megan McGregor. Next slide. So now that you know who's running the show today, we'd like to know who our audience is. So you'll see on your screen, there's a poll. And if you would just take a moment to answer for us, which of these categories best described your work? And we'll give everybody a few seconds to respond.
This is great, everyone. We have a great response on the poll, so thank you. I'm going to go ahead and end it and share the results.
Well, it looks like majority we have crisis workers, social workers, and state leadership. Let's see what else. We scroll down, lots of program managers and other. Kind of assumed other would be there because this is not totally inclusive list, but thank you for providing that information. It's super helpful for us to know who our audience is as we go through this work stream so that we can make sure we're giving the information that you really need moving forward. So now I'm going to hand it off to Stephanie Legallo, who's going to dive into our SUD integration work stream.
Hello, everyone. I'm not sure if you can see me, but thank you so much for being here. I just want to recognize that I know you're all very busy and have so much going on during the day. So taking your time out to be here today really means a lot to us. So for SUD integration in this work stream, we are going to look at a lot of things and bring you numerous resources. And today we're looking forward to even getting some feedback from you about what we're planning on delivering. So the goals of the work stream, not necessarily this workshop in particular today, are to support the integration of substance use services at all levels of the crisis continuum, to reduce barriers to integration, to provide resources and professional development to support system change, and to reduce harm and improve quality of life by promoting recovery across the continuum of care. When developing this work stream, we were really thinking about 2 pieces to address, and that is system integration efforts, but also bringing skills and resources to staff members that are providing direct service on the ground. Next slide, please. So for all of us in the field, we know that SUD integration tends to hit almost everything we do in our work. So I've been in the field for about 23 years, and I've been able to work in a lot of different states. I was very lucky to work in a state that did integration early, but the interesting thing about that state is it has deintegrated a couple of times since. So with integration, sometimes we have seen efforts to move forward, and then at times systems deintegrate again. So this is still an area that needs a lot of work in our entire behavioral health continuum. This slide is pretty cool because it shows how SUD integration fits into that whole continuum. So first, we have treatment and recovery support services. I'm sure there are folks who are on this call today that work in that realm. And so these are things like recovery support services, team-based wraparound care, outpatient services, assertive community treatment, which is a service line very close to my heart, residential services, hospital, intensive, and inpatient services. And as we all know, we still have integration efforts and work to do in treatment and recovery support services. The next area is prevention and early intervention services. And some of you may be from that field as well, where we try to do a lot of work around public awareness, community recovery capital, outreach, screening, and brief intervention, which often happens even outside of the behavioral health system and happens in things like primary care, as well as harm reduction. And then we have behavioral health crisis services. So we have suicide and crisis prevention lifelines. We have mobile crisis teams, crisis receiving and stabilization facilities, peer respite centers, first responders, and withdrawal management. And this is a very wide list, and integration can be done at many levels, at the system level, at the state level, maybe even the program level. And there's a lot folks can even do as individuals to advance integration efforts forward. I am now going to pass things over to the 988 TTAC Senior Program Director, Tiffany Lombardo, who is going to talk more about the guidelines and definitions.
Thank you, Stephanie. Thank you again. I will reiterate for you all joining us today. In the focus of how integration is so important, one of the things we wanted to highlight is the new national standards, the new national guidance for behavioral health crisis systems. So in January of 2025, SAMHSA's 988 Behavioral Health Crisis Coordinating Office, in conjunction with the CSR-TTAC in partnership with us, released new guidance and model definitions for behavioral health crisis systems. Both documents, the 2025 National Guidelines for Behavioral Health Coordinated System of Crisis Care and the model definitions for behavioral health emergency crisis and crisis-related services, were developed through a lens of integration and a focus on the whole person. Both documents identify overarching principles to guide the long-term development of a behavioral health coordinated system of crisis care. These principles provide a foundation that ensure individuals and communities have appropriate access and support to engage in behavioral health crisis services. They include an integrated approach to crisis care services. This can specifically be exemplified through several of the principles primarily. For example, crisis services should be comprehensive, integrated, coordinated, and developed utilizing a systems-based approach. This principle highlights that services within the crisis system should be able to address all the behavioral health needs of an individual in crisis. This means that crisis workers should be able to assess and intervene with the full range of mental health and substance misuse. This principle indicates that all services should be co-occurring capable and designed to meet the needs of individuals who present with substance misuse, as well as mental health conditions. Additionally, crisis services should be accessible and responsive to the needs of populations served. This principle acknowledges that access to behavioral health crisis care services can vary significantly for different communities. Therefore, crisis services should be designed to facilitate access and utilization. This principle further highlights the importance of integrated services. Crisis services should be resiliency and recovery oriented. This principle focuses on the importance of identifying skills, strengths, resources, and positive behaviors in promoting wellness. This includes a focus on integrating peer support and recovery support services into our crisis systems. Crisis services should be responsive to an individual's holistic needs. This principle brings the focus back to focusing on the whole person. Crisis services providers should be able to respond to people with complex mental health, substance misuse, or other co-occurring challenges. The 2025 National Guidelines for a Behavioral Health Coordinated System of Crisis Care outlines 3 essential elements to the crisis system: someone to contact, someone to respond, and a safe place for help. Throughout these elements, substance use services are included and encompassed across the crisis continuum, once again highlighting the importance of integrated services through our crisis care. Additionally, the guidelines promote the importance of being able to develop a behavioral health coordinated system of crisis care that is an integrated system. This is highlighted through the administrative structure, oversight, and policy, communications and engagement, and accessible behavioral health crisis care. Next slide, please. Additionally, the 2025 model definitions for behavioral health emergency, crisis, and crisis-related services demonstrate how the overarching principles reinforce integration through the system and embed substance use services across all crisis system components and service levels. This is highlighted throughout the model definitions, and we can see that through no identified exclusionary criteria in any of the services for individuals with substance use needs. The only caveat to that is in a safe place for help, where if it's medically necessary for them to be in an appropriate care placement in a higher or lower level of care. Emergency and crisis stabilization services, you'll see, include withdrawal management and medications for opioid use disorder as part of their essential elements. The staffing requirements reflect the inclusion of substance use credentials, and sobering centers were recognized as part of the array of crisis-related services. Additionally, you'll see throughout the model definitions that core competencies for crisis workers and services within the crisis continuum include integrated knowledge, harm reduction approaches, overdose prevention education, opioid overdose reversal, and SBIRT, or screening, brief intervention, and referral to treatment. This highlights the importance of our crisis services being integrated and being able to treat the whole person. Next slide, please. That being said, it is my pleasure to introduce our guest speaker today. She is the principal and founder of Thriving for All, but I'll let her give her own introduction. So please join me in welcoming Madhuri to our presentation today.
Thank you, Tiffany. It's a pleasure to be here, everybody. As Tiffany mentioned, my name is Madhuri. I use she, her pronouns, and I've worked with the 988 network now since ahead of its launch. And one of the inspirations I had of wanting to become involved in 988 success was because I was a mobile ACT team director here in New York City, which is where I'm coming to you from. And there's lots of things in ACT that can be translatable to how you can effectively implement crisis services holistically. And so one of the things that I want to be able to offer you all is a framework, because I think when you're talking about integration of substance misuse treatment with overall crisis response care, often a lot of the things that I've heard with social workers, peer specialists, and folks across the care continuum is a deep feeling of overwhelm. How do I actually manage all the needs of this person at the same time? And so I'm going to hopefully offer a framework that's helpful that you can take to your teams to start to incorporate with cases that tend to have integration challenges and see if they help you identify solutions for them. Next slide. So for the social workers that are on this call, this picture is probably very familiar for you. But in general, I like to think about this framework using what's called the person environment perspective. We're also thinking about it as whole person care on this call, which I think is a really neat way of talking about how do you address all levels of influence that are impacting someone's life. So in this, you see pretty simply that there are micro influences, meso influences, and macro influences that can help or assist or sometimes be a barrier to someone's ability to be well. At the micro level, you're going to be talking about your biological concerns, your physiological concerns. This will include also your substance misuse if that is an addiction that you live with. At the meso level, it's going to be the people and places and things around you, like your community, your family. Maybe there's facets of your culture. If you are of a culture that the family unit or the community unit is important, those things may have an influence on your life. And then at the final level is the macro. And these are the systemic infrastructure challenges or access points that someone has to interact with that are impacted by things like law, social policy, institutions, certain facets of the way government is structured. I think it was really noteworthy that Stephanie said that, you worked in a state where there was integration and then there was deintegration and then there was integration. And I think that is something that probably a lot of folks on this call, myself included, have had to interact with. So the way that I want to demonstrate how you can use this is actually providing a real case example. And for context, this case example was with an ACT team. So understandably, the needs of ACT patients, since it is sort of the last ditch effort a system will offer to someone who's been really struggling with crisis and unable to regulate themselves, is that those folks tend to have a lot of different psychosocial issues that are impacting their care. But it's applicable here because that is a common thread. Often when someone has substance misuse challenges, as well as difficulty being retained in treatment, is an ability to be able to say, can I address what is the actual barrier that's preventing this person from being well? So I'm going to describe the case, and then in the next couple slides, I'm going to show you how we can break this case down at the various levels, and then at the end, tell you about how we utilize that strategy to be able to get this person some help that they really needed. This case description is brief, but I'll say that this person is a 28-year-old young male who identifies as Puerto Rican, Nuyorican, as we call it here in New York, diagnosed with schizoaffective disorder, polysubstance misuse, and is street homeless. Was attached to our ACT team, also had an AOT order, and was criminally justice involved, and had lots of involvement with different kinds of police mechanisms here in New York. This person has a childhood trauma history, as well as a lifeline to one family member who is his mom, but was facing a restraining order that was police enforced to be able to work with the mom as part of his care continuum. So at the micro level, what I highlight here about this client is obviously the diagnosis that he lived with, which was schizoaffective disorder, that he was really proud of being Nuyorican, that he was shelter homeless, that he was a survivor of childhood sexual abuse, that he was struggling with polysubstance use, and he had had multiple overdoses, which contributed to his inability to regulate sustainably. And lastly, that he had, this is an overlap with micro and meso, but had overlap with criminal justice and AOT involvement. The next slide. At the meso level, we wanted to acknowledge some things around him, that he really wanted repair with his mom, but his mom was a Spanish speaker, and so it required us to offer that service in a bilingual capacity. He had lost his brother to suicide, and it was a catalyzing force behind one of the reasons why he was using substances to medicate his emotions. He desired a GED and a job. He was young, really wanted to feel like he could contribute to his community, which was Washington Heights, New York, his lifelong community, one that he was really proud to be a part of and felt very connected to. He actually had a positive relationship with his parole officer, which doesn't always happen, but this was a person who we started to think about as an ally and trying to get him into the right level of care. And at the time that we were working with him happened to also be the COVID-19 pandemic. And so he had recently recovered from a COVID-19 diagnosis after being released from Rikers Prison, which is the largest prison we have here in New York City. Next slide. And at the macro level, this person obviously had criminal justice involvement, had this police enforced restraining order with his mom, had this AOT, assisted outpatient treatment involvement. He was shelter homeless, and he had a deep mistrust of the medical system. As you all know, when someone's interacted with a crisis response mechanism frequently, often they also often feel traumatized by that interaction. Not a lot of folks are met with compassion, which is such a beauty of the premise of 988. And so this was a person who was really struggling to understand how we could help him along the way. All of these characteristics can make this case very complicated, but one of the things that we noticed that was the hardest for him to be able to approach sobriety, be able to engage in treatment, was that he didn't have a place to live. Here in New York, we had a housing voucher program during the pandemic where the city had partnered with local hotels that were empty to be able to give some folks who were unhoused a safe place to stay and quarantine. Housing ended up being this person's ticket to being able to be well, feel like he could integrate himself into substance use treatment, and also understand the value of that treatment being integrated into his overall mental health care. So I'm really pleased to share that because we could kind of break down the needs of this client that we had, we were able to effectively make a lot of changes following addressing the foundational need that he had, which was that he needed a place to be able to sleep regularly. And that included being able to repair with his mom, being able to actually get off of his AOT order. And I'm pleased to share he was able to graduate a GED program and get a job. So when you start to think about these things in this way, it makes it sometimes clearer to find the entry point to help someone who feels like they might be in a cycle that they can't break through from, and also compassionately not stigmatize them for feeling ashamed, as my client did, for being unable to successfully remain remission from relapse, which was really important to this client because we wanted to address all facets of the things that he was really excited for. And hopefully that this is a framework that can be something that is helpful for all of you as well. So the last things I'll put here is to learn from a case like this, which is clearly probably on the higher level of complexity in terms of how you approach them, is to consider all levels of influence impacting the person in crisis. Consider what other sectors in your community need to collaborate with you to de-escalate. In this case, we really had to work with a few. We had to work with the criminal legal system. We had to work with the housing system. We had to work with the mental health courts in order to be able to get him all the care he needed. And so the onus was on us to be able to effectively communicate with those entities and get their buy-in to feel like they were part of his care process. I also ask you to consider what familial, cultural, and societal dynamics are relevant. With this case, mom was not an English speaker, and so it was really important that we had ability to communicate with her in her language so she could know what her legal rights were and also how she could work towards repair with her son. As well, his Washington Heights community was really, really important to him. So for him to feel like he could safely be in that community, we had to work with that community, including the precinct and some community leaders who were invested in helping a lot of our clients who felt like they wanted to return back home. The last thing is to consider what strengths you can leverage with the client to foster hope. This is an easy thing to say, sometimes a harder thing to do, but with this client, he was really motivated to get a GED, get a job, and start playing basketball on the weekends. And so rather than focusing a lot on majority of our time on the crisis elements of his case, we kept talking to him about the connective tissue between that and getting him to a finish line that looked at like a capacity to be able to do that. And we did it under unprecedented circumstances during COVID, which really taught me that so long as we can sustain some visibility and hope and potential for our clients, more often than not, we're going to be the ones who help them see that for themselves. I think that's the end of my segment. Thank you.
Thank you so much, Mathuri. This was incredible, and we're really lucky to have had you as a guest today. So I really appreciate you being here. I think it just makes the work a lot more real when we can talk about a specific individual and how they benefited from integration. So we're going to talk about some opportunities and challenges in integration now. And I really encourage folks to chat in the chat box if you'd like. What are other opportunities or challenges that you notice, or any thoughts at all that you might have? So you can go to the next slide, please. So there are a lot of opportunities in SUD integration, and I don't think that they end here, but we're going to start to talk about some of them today. So the first is we can always assess for readiness. And if you're doing any work with individuals with co-occurring mental health and substance misuse now, you may already be doing some readiness assessments of some sort. So there are many different ways to look at if your system is ready, sort of depending on exactly what you're going to look at, right? The whole system, the organization, a program. And so we will provide you some more resources as time goes on to be able to do some of that change readiness assessment. Another opportunity is developing one pathway for access to all services. And so you may have heard of this referred to as like there is no wrong door. With 988 in particular, I think some of the challenges around one pathway have just been the phone number. In some states, there are multiple phone numbers to access crisis system services, and that can be really confusing for people on the ground. Being able to implement protocols and policies for responding to crises that involve substance misuse is a very big opportunity in integration. It allows you to think through how you want to handle situations before they end up happening. We also can get a much better understanding for the risk for individuals with, for suicide for individuals with co-occurring disorders. And we will be offering a specific workshop around that topic that we'll talk more about in a few minutes. Developing cross-training programs is a huge opportunity, and you can do this in a lot of ways. I love cross-training because you can often utilize expertise you have with your coworkers or other team members to train each other, to share knowledge, to really get the benefits of working in a team by learning from each other. And we have a huge opportunity in being able to engage those with lived experience to design the best and emerging practices for integration in crisis care. Next slide, please. We also have opportunities for whole person care. As we just heard, there are different ways to be able to look at an individual and figure out how to help them better depending on what they're dealing with. And individualized treatment is a core piece of whole person care, right? We're not just doing one size fits all treatment. We're really getting to know folks and understand what's important to them. We can focus on relationships, and relationships are really strong when it comes to SUD integration efforts. Relationships often predict sort of how folks do in a system. And so we can focus on these relationships, not just at the client level, but one missed opportunity we often see all over the behavioral healthcare continuum is not engaging family as well as we could. We can also focus on relationships at the system level to build collaborations and coordinations that will help with SUD integration. The stress vulnerability model came out in 1977. It's a model that I often think about. And really what the stress vulnerability model says is that stress is what often leads to people experiencing symptoms and difficulties. And how can we reduce stress as a prevention measure, but also how can we reduce stress to increase individuals' resilience? We can save money. We've known this for a long time when it comes to integration efforts, yet we still really struggle with integration, again, across that whole behavioral care continuum. We often see better outcomes. So we've talked about assertive community treatment quite a bit in this webinar, and assertive community treatment has shown us the cost savings and better outcomes for individuals that have both mental health and substance use disorders. We can also increase efficiencies. If we have different phone numbers, different resources, depending on what somebody is experiencing, if we can combine those, we can often just be more efficient all around. Can move to the next slide, please. And then we have some challenges in integration, as you all know. We still have a lot of separate funding streams. The federal block grants for mental health and substance use continue to be separate. We have a lack of SUD integration in all of our systems, our behavioral health systems and our public health systems in general. And oftentimes we're paying attention to a piece of the person instead of the whole person. Substance use and mental health are often viewed as separate in crisis response, and oftentimes people don't have the co-occurring disorder capability that they need to be able to respond in a way that aligns with best practice. There's a lack of training in general across the system on COD and SUD competencies, and we're going to talk a lot about that in this work stream. The awareness campaigns so far, specifically for 988, have often been focused on mental health. I've been working closely with a couple of states who are now trying to figure out how to integrate SUD into those awareness campaigns. And then, as we've said over and over again, lack of whole person care at all levels continues to be a challenge. And so any ways that we can work on integration as individuals, programs, organizations, systems is very important. I'm going to now pass things off to my coworker, Megan. Oh, actually, I have one more slide. Sorry. We're going to talk about well-designed plans for a minute. So I've been lucky enough to travel across the country to talk with people about their integrated services. And one thing I often say is, if you don't document something, it never happened in our worlds. And I really think of planning in the same way. If we don't plan for it, it likely isn't going to happen. But we also have research that shows us that well-designed plans lead to better outcomes. A lot of this research comes from the fidelity world and evidence-based practices. And there are different ways to do plans, but really thinking about planning and integration efforts is an important piece to the puzzle. Now I'm going to pass things on to my coworker, Megan. No, I'm still not going to do that. Okay. Sorry, y'all. We're going to talk a little bit about the work stream. So here's where we really hope to get some input from you all about how things are going to look with opportunities on this work stream. So first of all, we'll have ongoing technical assistance. Today, at the end of the webinar, we also are going to have office hours where we could answer some questions and also talk to you a bit about some of the specific technical assistance that we offer. We are going to have a webinar series. So next up is our mindset and philosophy. And we're going to talk a lot about how important mindset and philosophy is to integration, that it really is the stepping stones to getting to a place where services are integrated. We're going to talk a lot about the harm reduction in crisis care utilizing the SAMHSA harm reduction framework. You all may be familiar with that framework already. And then we are going to look at best practices for assessing suicide risk in co-occurring disorders and substance use disorders. Last but not least in our webinar series, and you may have heard of the community resilience model before. Some of the addiction technology transfer centers have brought this model to the country. And this model helps anybody who is dealing with a stress or a crisis. And so the model is generalized for everyone of all ages, and you don't have to have a specific degree or set of credentials to be able to utilize that model. We'll also be doing a DBT skills learning collaborative. That collaborative will be done in two ways. So we will do more of a supervisory level collaborative, but then we will also have a direct care staff collaborative. And what that means is we'll have many different sessions that talk about the dialectical behavior therapy skills and how those can be translated to integration. Last but not least, we will bring you a toolkit that will have different components to that toolkit. And the pieces in the toolkit will be SUD and COD competencies for crisis workers. So we'll really go into those competencies in great detail. Then we are going to do a piece on harm reduction. And last but not least, integration culture change. So really talking about some of those pieces around mindset and philosophy, around action planning, and how important that piece is to culture change. Now we are actually going to take some time to answer questions. And then after that, we will then be moving on to my coworker, Megan, who is going to get some feedback on what we talked about today and what other ideas and needs that you all have. So I'll just pause us for a moment here for questions.
Yeah, feel free to use the chat for questions. If you'd like to come off mute, just raise your hand. We'll give you the ability to speak out loud, but either way, please bring your questions.
So we've had a question come through the chat. Brenda said, I've actually seen more organizations have staff trained in SUD response, but not have the expertise to care for someone in a non-SUD induced mental health crisis. I appreciate the definitions guide and hope that at some point there will be a standard of care to include suicide care. Any further thoughts?
I think that's something that's very needed. I think your comment is going to resonate with many people here. Like Stephanie outlined in this work stream, we will be talking about how to assess the risk of suicide in co-occurring disorders and substance use disorders. We'll also have that portion of the toolkit on harm reduction, which I'm sure will be covering some of the suicide risk. So I'm hopeful some of those resources and learning opportunities will give you some of what you're needing in your work. But it is nice to see that you do have some skills around the SUD related crisis because we don't see that very often. So maybe we're working a little backwards with you from what we've seen happening, but that's okay. I think you'll still get some of those tools throughout this work stream to better support working with the suicide risk around substance use. Stephanie, I don't know if you want to add to that.
No, I'm surprised, Brenda. This is great news that you feel pretty confident in that SUD response training. We agree that being able to respond to an individual who is in a crisis, that the person may be experiencing suicidal ideation, that's a really important piece that we hope to bring you more resources on. Any other questions? It looks like another one just came in. Do you want me to read it, Tiffany, just since I'm off mute?
Yeah, go for it.
Okay. Does the withdrawal management include medically supervised withdrawal management with induction of meds, or is it along the lines of detox? My guess is this is related to like the guidelines and definitions, Tiffany.
Yeah, so Pam, it's really based on what level of care and what specific service component. So based on the different categories and the different service components in a safe place for help, it really depends on what level of service component that is. There is a push for the idea of supervised withdrawal management and induction for the higher level levels of care. And but there is a full continuum there, right? So there is like the sobering centers, which is a crisis related service, is really just focused on detox and sobering, versus really having that induction and having that referral. So it depends on the service. I encourage you to take a look at how the model definitions and some of those crisis service components have been outlined in the guidelines, and what we're hoping to see in a full behavioral health coordinated system of crisis care, which is a mouthful. And what SAMHSA is hoping to see, and what hopefully communities can build off of.
I see this next question, which will you have topics specific for youth and SUD, COD, and a behavioral health crisis? This is a great question and definitely something that we can bring into what we have planned for this work stream. And I know we also talk about this in other work streams as well. So we'll take this piece of feedback. Thank you.
So the next one, Megan, I think this is up your alley too. There's a lot of information and trainings on suicide prevention and intervention, but not very much on suicide care, recovery, and bringing the message of hope. Please advise and share your point of view.
Yeah, so I agree with you that prevention and intervention have kind of been at the forefront of our suicide prevention world. However, I think the shift has started where we're seeing a lot more work in postvention. I did specifically see on this call a former colleague of mine from Connecticut who has done a ton of work in postvention and has some really good strategies that have been used throughout the state. But I do think that we are starting to see the shift towards focusing on that follow-up care, postvention, not only for the individuals involved, but also for the communities as a whole. So I do think we are seeing a shift. I think it's going to take time, like most things have, but we firmly believe that postvention is prevention. So I'm hopeful that you will start to see more of that. But please feel free to connect with us, and we're happy to provide additional resources that do exist as you kind of build that infrastructure for your organization.
Stephanie, did you have any thoughts to add?
No, I agree with what Megan said. And I know that we're also running a little short on time, so I'll take us to the next comment, which is really just a comment. But thank you, Pam, for sharing that BJA did release some guidelines for jails, withdrawal management guidelines, but it applies to all settings for anyone who is interested, and she shared the link. So thank you so much for that. Somebody also asked, will the upcoming series and toolkit also provide support and strategies to navigate federal regulations and reimbursement structures? These rules often seem to be a driving factor for de-integration of SUD. Yes. Thank you, Megan. Great question.
Okay, so we will have office hours following the workshop. If you want to stay on or you have additional questions or comments that you'd like to discuss, we will be available then. But we want to make sure that we are respectful of everyone's time and that we move on, because we do want to hear from you and have an opportunity to hear your opinions on topics and areas and focuses that we can take a look at as we build this work stream and continue to move forward to ensure we're providing you all the resources and support that is pertinent to your work. So I believe that is Megan's cue.
Yeah, so we're going to do an activity now as we start to close out. So we're going to be using Menti. On your screen, you should see the QR code if you'd like to scan that to participate. At the top is the website and the user code that you can do. So once you're logged into that, what we'd like you to do is, using a word or a short phrase, what are you most excited or hopeful for in participating in this SUD integration work stream? I will share that I am most excited for introducing that assessing for suicidality in substance use disorders, because that is where I focus most of my career. But use that QR code or log in through that website, and we'd love to see what you're most excited about. I'll give everybody a few minutes to participate.
Megan, just FYI, I did respond and it is not coming up in the responses.
Let's try a different option.
We had a feeling this might happen, y'all, so we have a plan B, so please be patient with us.
See some responses. All right. Can you all see this?
It's trying to share your screen. There we go. All right, great.
Awesome. Well, let's see what we have. Whole person care, resources for hope, new trainings. decreasing stigma, suicide assessment, intersecting efforts. That's one of my favorites. I thought this would look cool, but it keeps moving every time I go to read one, so that's fun. Withdrawal management, coordination, quality care, collaborating with others. I think this work stream gives us so much opportunity for that collaboration. There'll be some great knowledge exchange. Standardization. Versatility of assistance. Yeah, I think we all know that the flexibility to provide support is so essential in the work that we do in substance use disorder. You can keep answering this one and we will kind of collect these responses for feedback, but we do have another question for you. Here we go. Same thing, you can scan that QR code or you can use the code at the top. We'd like to know from your perspective or from your specific role, what opportunities or resources do you think we're missing in SUD integration right now? Role play training examples, absolutely. Local connections, lots of youth resources, family focus, warm handoffs to local resources, long-term supports. Of course, the QR code is blocking that one. More insight into connections to primary care. I love that idea. Yes, resources, different language, ensuring accessibility for everyone. Natural helpers. Oh, it was funding streams to support integration. Other community supports, more insight into detox access. Innovated SUD treatment and care in rural and remote communities. Absolutely. Stories of hope. Yeah, I think like Stephanie talked about earlier, finding those opportunities for lived experience voices to be heard. More motivational interview training. Breaking policy barriers. Rated funding, yes. Hospital buy-in. Collaboration, politics of change. Wonderful. All right, I'm gonna stop for just a second and pull the final one up. All right, and same drill, you can use that QR code or you can use the login code at the top. But now that we're done with this session, how are you feeling? Excited, I love that. I'm glad, I am too. Hopeful. Energized, enthusiastic, encouraged. These are so positive. I love this. Stephanie, you did a wonderful job organizing all of this. Everyone's so happy.
Megan, this slide is really cool because once somebody answers like hopeful more than once, the word gets bigger.
No, this is exciting. Empowered, overwhelmed a bit. Yes, I can understand that. This was a lot of information and we have some high hopes for this work stream, so it can be a little overwhelming. Empowered, encouraged, gratitude. I love that one. Informed, thankful for the 988 opportunity. I think so many of us knew how needed 988 was, but we had no idea how impactful it would become. Nervous, that's okay. Curious, I like that one. strengthened. In the chat, we have gratitude and optimism. Overwhelmingly positive sentiments. Thank you so much. Again, feel free to keep adding those in. But I do want to share with you, as we spoke about a little earlier, those upcoming events. Let me share with you the slide deck again. There we go. So here's a listing of some of our upcoming activities in the 988 TTAC. So you can scan that QR code, and Stephanie put the link right into the chat for us, so you can see what our upcoming offerings will be.
And these are the offerings for the whole TTAC, obviously not just the specific work stream. So you'll be seeing more from us, as Stephanie laid out, over the course of the next year, with specifically the targeted topics we discussed today. But these are our May events, or the remainder of our April event, too. For we've got one next week. So we would love to see you if they, you know, are things that are important for you or apply to you and your community or services. So we have plenty of offerings, so we would love to see you at some of our other webinars as well.